A very good afternoon to all present here. At the onset, I would like to first thank the organizing team of MAPICON for giving me this opportunity to share the stage with brilliant speakers, great researchers. So it's an honor to be here today. So what I'll be talking about today is age. Does age matter? Yes. Uh, the need to establish geriatric specific reference intervals in laboratory investigations. So broadly, we'll be discussing under the following headers. I'll give you the overview first, then the introduction to the reference intervals, the importance of geriatric specific intervals, challenges faced in developing those intervals, a few reviews, those studies who have been done so far, and the steps in that would be involved in establishing the geriatric specific reference intervals, and finally the conclusion and the recommendations. So to begin with the improvement in the health infrastructure, the facilities, and the general lifestyle of the people, the life expectancy of the individuals have increased. With that, to an extent that there has been inverse demographic pyramid has been observed, which has come to the eye of professionals, the general public, and the lab medical personnel. Now, what is the concern here? The concern is that by 2050, the geriatric population, that is the population above 60 years of age, it will almost double, highlighting the increased need for age-specific medical practices. Also, the geriatric population is unique in the sense that they have their own challenges of cardiovascular diseases, diabetes, osteoporosis, those multitude of limitations happen, challenges happening simultaneously. And with that, with our own understanding, or maybe if I can put it that way, mental blocks that we, the health structure also, the health professional also have to adapt now to developing geriatric specific, not just practices, but also specific diagnostic parameters. So I being a biochemist, so just an overview of what we do in the laboratory. So basically whatever samples, be it blood, urine, or any kind of body fluids that are received in the laboratory for analysis, the results are interpreted in terms, quantitatively in terms of numerical values. Now, these numerical values are then used to interpret clinical information. Since they are numerical values, they are reproducible, they are comparable, and at the same time, they can be used for as a very good tool for evidence-based medicine. Now, since these are numerical values alone do not stand any merit. They have to be interpreted in light of something. Now, that something is the reference intervals. So, if you look at the reports, what we receive from the laboratories, usually the patient results would be given, and in that, just next to that would be mentioned the reference interval. So, reference interval usually what we say is it depends on the equipment used, the platform used, or the method on which it is based. It also depends on the gender of the individual. However, the biggest limitation as far as India is concerned is we do not have our own references. So we are borrowing those references from the Western world. Now their genetic makeup, their ethnicity, everything is different. And to cap it all, now we have a geriatric population increasing where we do not have any reference points. So that makes the things still more difficult. Now, what is this reference interval? It is based basically on the statistical standard statistical distribution of the test results which are obtained from the normal population, adult population. Now, normal synonymous to healthy. So that's the healthy population is selected, and then from that the reference intervals are drawn. Now these encompass around 95 percentile of the Gaussian normal curve. That means to say that there would be still 5% of the population which would be normal with no pathological correlations seen, but still they would not be they would not fall in that reference interval. That means to say we have to be very cautious. It's not just flying rockets ki agar if the reference interval is from 2 to 4, then 4.1 becomes abnormal. So that's the idea of saying that it, with all the hard work done, investing so much, we are actually still left with that 5% population who would be normal but yet not fall in the reference interval. So what is the reference interval? Now, reference interval, it represents the range of values that are expected to be there in the healthy population, and it is used for the healthcare providers to interpret laboratory results. What is the importance? It distinguishes between normal, abnormal, helps in decision making, follow-up of the patients, treatment of the patients, and even for some tests, even prognosis. The limitation here is that most of the reference intervals which are drawn, the population used for drawing this reference interval is in the age group of 18 to 65, excluding the geriatric population. So whatever reference intervals we are having presently, they are not catering to the needs of the geriatric population, and that's what should be now a thinking point, that should, since the population of geriatric population is increasing, should we not be developing their separate reference intervals? So how are these intervals drawn? The reference individuals, they comprise of the reference population from which is selected the reference sample group, and this is used to determine the reference values which are on which is observed the reference distribution of from this distribution is calculated the reference limit, and from this limit the reference interval. So individuals are picked up from the population. From the population, that individuals which are picked up, they are basically a small group which are a reference group, and from them are drawn the values, study the distribution, draw the limit, and then the reference interval. What is the importance? Why age matters? Now, geriatric population has some unique features in the sense that there are certain changes which are happening physiologically as regards to the geriatric population. So those have to be considered while defining the reference intervals. That could be reduced renal function, the changes in the metabolism, altered immune response, and especially those that can impact the lab values. So in that light, the values, whatever values we are getting, they have to be interpreted. Now, making these reference intervals for geriatric population is more critical in the sense that since the physiological changes are happening at every level, in all the intervals of the population, let us say 60 to 70, 70 to 80, 80 to 90, unlike the adult population where we are using a broader range. So we have to break them into smaller groups to study the effects what these physiological changes are producing on those analytes of interest. Now, using the reference intervals of younger adults to interpret the health status of geriatric population eventually leads to either misinterpretation, over diagnosis, or under diagnosis of disease states. Just a few examples which I have picked up from the references available on studies which have already been conducted. Before discussing that, I would like to mention that these studies, the basic limitations here again are that these are very few studies from India, and that too the sample size is very, very small. So really saying that these values are representative of the population and we can draw reference intervals from that would be difficult to say. So as you can see here, creatinine values do tend to increase a little, but the problem with creatinine is that as we age, the renal function tends to deteriorate by 30 to 40%. That means the functionality goes, and also the GFR. But simultaneously, that means if the renal function is going, the creatinine levels should increase. But that doesn't happen because simultaneously the muscle mass is also decreasing, the nutritional status is also going down, the dietary intake is also decreasing, the muscle mass is going down. That means to say that if you are not able to excrete the excretory product, we are also producing less. So net effect is that we would be maintaining normal creatinine levels in the geriatric group even if the renal functions are deteriorating. So for that, in that case, study of the urinary creatinine levels would be a better choice, because that's more reflective of the GFR rather than the serum creatinine, which combines both. It is affected by GFR as well as the affects the GFR as well as it's affected by the muscle mass. It's more important again to know the renal function in case of geriatric population, because again the dosaging for of various drugs has to be tailor made to the requirement of the geriatric population, and since they are aging and their renal function is going down, with the same dosage what is given to younger adults may be toxic for the geriatric population. So that would be another challenge to treat. Coming to the glucose levels, as we can say, the glucose levels, as we go from 80 above, the glucose levels tend to increase. So the serum glucose levels increase. Parallel to that, there is decrease in the glucose tolerance. The glucose levels can also decrease if there is a case of malnutrition. So the results have to be interpreted in that perspective. That means there has to be correlated clinically. But there is higher serum insulin levels seen, which suggests that there is associated insulin resistance happening. And uh, this is probably responsible for the impaired glucose tolerance seen in around 25% of the individuals over 75 years of age. Now, there is also decreased levels of calcium, increased levels of calcium initially till 90, and beyond there is a sudden dip. The increase could be attributed to decrease in pH or increased levels of parathyroid hormones, and it removes the calcium from the bones to in an attempt to increase the blood calcium levels. However, the significant decrease in albumin does contribute to decrease in calcium levels, so that could be a thing to watch for. Now, this was a study, it was a ICMR funded project by the name Geriatric Friendly Clinic, Primary Healthcare Approach. This, in this study, I think it's probably the only study as of now I can recollect, or I've seen literature, more than 5,000 geriatric population was population of more than 5,000 individuals was studied in this, and I was fortunate to be part of this. Wherein the primary objective was to demographically map the population and then divide them into groups. The in the second phase, wherein the main idea was to provide them care, so they were stratified into people at individuals at no risk at all, little risk, or high risk, and then the attempt was made to convert the higher strata into, bring the patients from the higher strata into the lower one, so that they can be managed likewise. Albumin, I've already said, albumin levels are decreased, and that can also contribute to low levels of calcium. Now, other liver function tests are also affected. Cholesterol levels, again, the cholesterol levels tend to increase till the 6th decade. Then comes the plateau phase, and it starts decreasing. So that means beyond 80s, the levels of cholesterol would decrease. But also cholesterol is also a marker of malnutrition. That means to say, two independent variables decreasing cholesterol levels should be interpreted in a way that the decrease, the sudden decrease in the cholesterol levels, there are studies suggesting that it can be taken as an indicator of worsening of life expectancy prognosis. So as I've already said, cholesterol levels tend to increase initially and then decrease. As in case of women, since the protective effect of estrogen is gone after menopause. So their predisposition to cardiovascular disease is almost equivalent to that of males. There is significant, if you can appreciate that in the geriatric population, the levels of T4 are significantly lower compared to that of the normal younger adults. So there is hypothyroidism seen in around 2 to 6%. So that's what we are trying to say is that that is part of the natural aging. So there are so many parameters which are suggesting that there is natural aging happening, with that affecting the parameters. Hence, it becomes imperative to develop our own reference intervals specific for geriatric population. So similarly, the hemoglobin levels also tend to fall. These are certain references all suggesting that the different analytes for the reference intervals for different analytes for geriatric population need to be developed. However, the limitations for most of the studies are that they are not Indian studies, and the population of study is very little, around 100 odd population. So the challenges are that most of the reference intervals are derived from the younger population, and it is extrapolated to that of geriatric population, whereas we are not considering the comorbidities or the medications involved. There is physiological variability, which is not considered when we are talking about the younger adult reference intervals. There is a continuous progressive aging happening, and so the continuous change in the progressive change in the analytes as well. Hence, again, it emphasizes that we should be developing our own reference intervals for the geriatric age group. Again, ethnic regional differences like younger adults. Similarly, for geriatric group as well, they do contribute comorbidities and medications, because most of the geriatric population is on medication. So it's really difficult to interpret in the sense that what would be the true value, the normal value actually, had they not been on medication, because most of the population under study would usually be under one medication or the other, or maybe a poly pharmacy, they would be taking more than one medications. Fair and Campbell, they had demonstrated that in older adults, failing to make a diagnosis when the disease is present, or making a diagnosis when the disease is not present, is likely to occur twice as often as in younger adults. Again, emphasizing the fact that there should be separate reference intervals. Besides defining who is healthy, who is sick in geriatric population is a very subjective thing. So that again increases the difficulties of defining the population. And then theoretically, what things are not important otherwise become important in case of geriatric population. That is the contributions made by impaired mobility, nutritional status, seasonal influences. They do have a significant role in case of geriatric population, wherein may not have as much in case of younger adults. What we can do, we can recruit healthy individuals, clear-cut marking the inclusion-exclusion criteria, standardizing these sample collection protocols just to avoid all the pre-analytical errors. Then consider age-related changes. That means account for all the physiological changes what are happening in the geriatric population when we are trying to define the reference intervals for geriatric population. Use of robust statistical methods, and regular review and update, because most of the places we are not even, physicians may not be even aware in the periphery that there is a requirement for developing the geriatric reference intervals also. So spreading that message, that understanding that now it's time that we should be looking for age specific, specifically geriatric population specific reference intervals. The benefits, in fact, if you are looking at whatever we have discussed so far, precision medicine, if it has to be applied, this is a good group to do it for, since it's more individualized. As I said, you cannot have a broader age group to define the intervals. It has to be broken into smaller groups because there would be still differences between age groups of 60 to 70, 70 to 80, and 80 to 90 and above. So precision medicine, personalized medicine would be something we should be looking for. It will help us avoid over-treatment or under-treatment of geriatric population and eventually improve diagnostic accuracy. So conclusion is that we should be looking for age-specific, developing age-specific reference intervals. The current gaps, that means using the younger references for adults should be for the geriatric group should be avoided, and collaborative research should be encouraged. Since I said the major limitation is lack of data, a comprehensive data. So multicentric studies should be, in fact, recently ICMR has initiated a multicentric study which is happening now in 6, 7 centers across India, of which fortunately AIIMS Bathinda is also part of, which will be contributing to developing the reference intervals, not specifically for geriatric, but overall. But it's a good initiative. At least we'll have our own Indian reference ages, so that's a great thing. Thank you for your time. Thank you.
Thank you very much. Excellent talk, making aware people that 20 years and 80 years reference age will not be the equal. So what we are doing is we are generally following the Western data. So it is great. Congratulations. Dean Research is here. Associate Dean Academics is here. And you have given you are part of that ICMR project. And that is great to know. Thank you very much. And congratulations for that project. Thank you.